Welcome to this educational video from the Canadian Association of General Surgeons. This video will provide a basic overview of the technical and anatomic considerations necessary for safe and efficient colonoscopy. For anyone new to learning colonoscopy, or anyone who remembers when they first learned, I don't need to tell you that colonoscopy is difficult and humbling, even for those now with years of experience. For surgeons, it is a very different skill set from open surgery or laparoscopy. Envision laparoscopy done with long floppy instruments and a long floppy camera operating on a long floppy organ. Yet ever advancing techniques, increasing indications, and an aging population all demand an ever improving skill set. The purpose of this training video is to provide insight into the technique of colonoscopy and to teach you how to become a skilled, efficient, and safe endoscopist. The technical objectives this video will help you to achieve are as follows: to advance the scope to the cecum or terminal ileum. A high cecal intubation rate alone is inadequate. We need to get to the cecum with a short scope devoid of loops. We should be able to complete the majority, if not all, procedures, never having more than 110 centimeters of the scope inserted. We want to achieve good visualization of all mucosal surfaces. The procedure should be completed in a quick and efficient manner, and we should be able to do all this with minimal stress and discomfort to the patient. Pain and discomfort is most frequently caused by longitudinal stretch on the mesentery, usually due to loop formation. Discomfort can also be precipitated by overdistension of the colon from excessive insufflation. CO2 is far better in this regard and should be considered the standard of care. There are a number of early and late cues to the endoscopist that you may be at risk of causing pain to your patient. Visual cues include paradoxical movement in the scope, where despite advancing the scope, you either remain in the same location or fall further back on the screen. This is suggestive of loop formation. This can also be visualized with the ScopeGuide. Later cues include a feeling of torque or resistance in the scope, either axial or rotational, or even loops in the external portion of the scope after a prolonged struggle to negotiate a turn in the colon. The final cues come from the patient, including tachycardia or bradycardia, or verbal complaints of pain. The endoscopist should be capable of providing endoscopy with or without sedation. It should be patient preference that dictates the degree of sedation for what is a highly invasive test. The goal of quality endoscopy practice is not to minimize sedation, but to be able to provide endoscopy with minimal discomfort, regardless of the degree of sedation desired by the patient. The first and perhaps most important thing to touch on is how to hold the scope. The umbilicus should be positioned behind the wrist. The scope should be held horizontally during insertion and withdrawal in order to minimize torque. Conversely, holding the scope more vertically with the left hand can help stabilize the scope when necessary, such as during polypectomy. During insertion, keep your fingers away from the insufflation button. Although many of us were trained to keep our index and middle fingers resting over the two buttons, it is preferred that neither finger rest over these buttons, and that they be pressed only when required with the index finger. This avoids inadvertent overinsufflation during insertion. Room setup is very important for safe and efficient colonoscopy. Appropriate ergonomics will help prevent injury to the endoscopist in the long term. The ideal setup includes the scope tower positioned behind the endoscopist. This will keep loops and torque out of the umbilicus of the endoscope. The monitor should be across the bed, as shown here, at or slightly below eye level. Because endoscopists come in a range of sizes, monitors should be adjustable. The bed should be positioned so the hips are roughly at the level of the scope umbilicus. The height will vary based on the height of the endoscopist, but as a general rule, the surface of the bed should be approximately 10 to 15 centimeters below the elbow to allow a comfortable resting angle for the forearm during the procedure. The preferred method of scope advancement for avoiding and reducing loops is torque steering. This technique involves applying rotational torque to the shaft of the colonoscope. This technique can be applied via the endoscopist's hand on the scope or by rotating the patient. Tip steering, although a valuable technique in many situations, is rarely required when advancing the scope to the cecum. Lubrication should be considered both internally and externally. Liberal amounts of muco should be applied at the anus and also at any portion of the gluteal folds that will be in contact with the scope. This is particularly important in high BMI individuals. Internally, endogenous mucus acts as a lubricant, but liberal amounts of irrigation during insertion of the scope will allow for less traumatic advancement around turns. Changing the position of the patient has three main roles. First, it can be used to optimize the location of air and water within the lumen of the colon. Second, it can utilize gravity to optimize the acuity of turns, particularly at the flexures. Finally, it can provide additional torque to the scope by rotating the patient around the axis of the shaft of the colonoscope. We will hopefully show how these changes in patient positioning can be utilized for scope advancement to avoid loops and arrive in the cecum with a nice short scope position. Left lateral decubitus is of course the ideal starting position. This allows for digital rectal exam and perianal inspection. The rectum is fairly easy to negotiate in this position. The sigmoid colon can sometimes be easily negotiated with torque alone in the left lateral decubitus position. But if it is redundant or challenging, supine position and even right lateral decubitus can be helpful. The descending colon will fill with air in right lateral decubitus position, allowing for scope advancement without any air insufflation. The splenic flexure is most easily negotiated with the patient in right lateral decubitus position. Compared to left lateral decubitus, right lateral positioning helps to decrease the acuity of the angulation at the splenic flexure. The transverse colon, when redundant, can dip down into the pelvis before returning back up again to the hepatic flexure. This can result in consumption of a lot of scope length. Positioning the patient supine can help the transverse colon fall back into the upper abdomen. This straightens the transverse colon, allowing the scope to traverse it with a shorter length of scope. The hepatic flexure is of course the mirror image of the splenic flexure, and thus is best negotiated with the patient lying in the left lateral decubitus position, again, to decrease the acuity of angulation. Finally, advancing the scope through the ascending colon down to the cecum can vary depending on the patient, and a degree of trial and error may be required. That being said, the vast majority of procedures will allow the tip of the scope to advance to the floor of the cecum with the patient in left lateral decubitus position. Failing this, supine, right lateral, and even prone positioning can be beneficial. When the cecum lies medially or is hypermobile, the cecal pole is best seen in right lateral decubitus position. This position can also help to visualize mucosal surfaces proximal to the ileocecal valve. Repositioning your patient while maintaining your scope position is a skill unto itself, but can be done efficiently when the tips shown here are followed. Repositioning the patient is of course easiest with either a minimally or unsedated patient who is able to cooperate and move themselves with appropriate instruction. If deeper sedation is being used, a slider pad may be helpful. As discussed, most scopes start in the left lateral decubitus position. Transitioning to supine, next, is the most common maneuver. The external portion of the scope is extended straight towards the foot of the bed. The patient is instructed to lift the right leg so the scope can be passed between. The patient then rolls onto their back with the right leg straight and the left leg slightly frog-legged. The straight right leg keeps it out of the way of the endoscopist, and the open left leg allows access to advance the scope. Rotating further to right lateral decubitus follows a similar approach to that shown before. This time, the scope is straightened and passed under the left leg. The patient rolls to face the endoscopist with both knees slightly bent. Keeping the patient slightly closer to the edge of the bed will prevent the endoscopist having to lean over the patient, leading to strain on the back. Finally, rotating to prone from either right lateral or left lateral decubitus is done carefully with patient instruction to remain centered on the bed, with the head tilted to one side in the recovery position. Water insufflation is particularly useful on the left side of the colon, where in the sigmoid it helps to weigh it down, preventing lengthening and formation of loops. Air insufflation is best avoided during the initial part of scope insertion, as it can overdistend the colon, leading to a more challenging cecal intubation in some cases. It is very useful, however, on withdrawal to help distend the lumen and make mucosal abnormalities more evident. External pressure can be provided in two main forms. The first and most common is abdominal pressure provided by the hand of a nurse or assistant. The ScopeGuide can be particularly useful here to guide where pressure will be highest yield. If looping is in the sigmoid, left lower quadrant pressure is ideal. In the case of a redundant transverse colon, upper abdominal pressure during scope advancement can help prevent the colon from dipping into the pelvis. Positioning the patient prone also allows external pressure from the bed. The other form of external pressure that can be utilized is that of the diaphragm. In patients with a particularly high splenic or occasionally hepatic flexure, abdominal pressure is limited by the ribs. In this case, the diaphragm can help push against the scope. Patient instruction to inspire and hold their breath while the scope is advanced can be very helpful in this otherwise challenging scenario. Suctioning must be considered not only for helping to cleanse the colon, but also for its role in scope advancement. Consider suctioning anytime you are advancing the scope through the lumen. It helps to accordion the bowel over the scope, minimizing the length of colonoscope that needs to be inserted to pass each anatomic segment of the colon. Most scopes have the ability to change tension and flexibility in the scope. Variable stiffness can be quite beneficial in some cases. The procedure is ideally begun with the stiffener at the lowest setting. Once the sigmoid has been negotiated, with the scope straightened, it can be useful to increase the stiffness to avoid further loop formation as the scope is advanced. While it is of course ideal to avoid loop formation entirely, occasionally loops may form despite our best efforts, and should be reduced if at all possible to maximize scope tip control and comfortable scope advancement. ScopeGuide can be very helpful in first identifying the presence of a loop early on and also helping to guide the success of reduction maneuvers. When reducing a loop, hook the scope tip around a turn or flexure. Apply either clockwise or counterclockwise torque while pulling back on the scope. When re-advancing again after the loop has been reduced, keep the same torque applied to minimize the chance of reforming the loop. We hope that this video helped you to visualize some of the dynamic changes to the colon during colonoscopy, and that you might be able to utilize some of the techniques shown here to enhance your own skill set. Thank you for watching.